Good day, everyone. We are waiting for people to join and get connected to the audio. If you could put your name in the chat. Colleagues who are in the Denver Health Clinic, welcome. We see you there. If it's possible for you to email me, everyone who's in the room, that would be great, just so that we can have an adequate attendance list. And we're just going to keep saying welcome for the next 2 to 3 minutes. Welcome, everyone. My name is Ty, pronouns he, him, his. Welcome to this learning convening, and we are so happy to have you all. We'll get started in around 2 minutes. Use this time to go grab some water or visit the comfort facilities, but we are happy to see everyone. Once again, good day, everyone. My name is Ty, pronoun he, him, his. We'll get started in about a minute. Go ahead and put your name into the name and pronoun into the chat. We are so happy to have you. Again, our colleagues joining from the Denver Health Clinic, if you could just email me the names of everyone in that room. Great, I see Yomi giving us a thumbs up. Hello, everyone. Just send me an email of everyone's name and contact information in that room. That'd be great. We're going to get started in about 30 seconds. All right, everyone. Happy Tuesday, May 10th. Welcome to this joint session of our West Region Learning Community and our Denver PTC Community of Practice. Today's a very special session. We are going to be doing part 2 of equitable access and representation in sexual health and PrEP services. Today, we're going to be focused much more on PrEP, but we are so happy to have everyone. Today's going to be a little different. We are going to mix things up. We are so happy about that. So if you could put your name and pronoun into the chat. If you are joining us and you are in a room where there are a lot of different people, just email me the names of everyone in that room so we can have that for our attendance list. And now I'm going to turn it over to our presenter for this morning, Dr. Riley Smith.
All right, thank you, Ty, and good morning, everybody. Like I said, this is our second session on the equitable access and representation in sexual health and PrEP services. My name is Dr. Riley Smith. I'm a family medicine physician at Denver Health and also an identity consultant with the Denver Prevention Training Center. I'm a transgender man. I use he, him pronouns, and then I'll let my co-facilitator introduce herself.
Well, good morning, afternoon, wherever you're residing. Thank you all for joining us. My name is Neve Anderson. I am the CEO and founder and sole consultant of Simply Be LLC, where I specialize in simplifying complexities regarding gender, race, and sexuality. And I'll pass it back over to Riley.
All right. And throughout this discussion, we want to encourage you all to utilize the chat box if any questions come up. You can also do the little raise your hand thing in your video screen or just unmute and chime in, but there'll be plenty of points where we can all kind of come together and discuss. So getting started, here's our agenda for today. So we're going to go through the purpose and our learning objectives. We're going to talk about taking a comprehensive sexual health history, and then we're going to really focus in on pre-exposure prophylaxis or PrEP for HIV, and then we should have time for plenty of questions and kind of to overview everything at the end. All right, so this COP is part of our part 2 of our series on equitable access and representation in sexual health and PrEP services. So like I said, we're going to discuss taking a comprehensive and affirming sexual health history, and particularly focusing on working with transgender and non-binary patients, and then focusing on PrEP and its importance in preventing the transmission of HIV. We're specifically going to go through the indications for PrEP, or for PrEP prescriptions or referral, how to ensure equitable access to PrEP for patients of all gender identities, and then the treatment and monitoring guidelines for PrEP in its various forms. Oops. Sorry, too fast. And here's those learning objectives. So we're going to describe PrEP and its role in the prevention of HIV, how to conduct an affirming sexual health history, indications for PrEP, and then monitoring PrEP areas. So before we get into talking about PrEP, I want to focus some on the best practices in taking a sexual health history that's both comprehensive and affirming, particularly with working with gender diverse patients. So to begin, I'd like to think about how we take sexual health histories, and this can be whether you're a provider or working in any realm of the HIV navigation services. When others are, I'm curious for other folks in the group, how you approach this when working with patients or clients. What kind of questions would you typically ask when obtaining a sexual health history? And you can unmute or type in the chat, whatever is easiest.
And Riley, just say that one more time, the question. So
yeah, so the question here is, what questions do you typically ask when obtaining a sexual health history? So good, I see Rebecca Reese saying, what types of sex are you having? Asking folks their preferred pronouns. Asking about condom use. Let's get one more. So yeah, asking about frequency of sex, and tell me about your partners. How do you receive pleasure? How do you protect yourself against STIs or pregnancy, if applicable? Great. So yeah, there's a lot of different, what genders are your sexual partners? Awesome. There's a lot of different ways that folks can approach this. What individuals do you have sex with? Great. One that I see come up a lot is something as simple as, are you sexually active? And then you might follow that up with something like, with men, women, or both. And then you move on and you don't ask any more questions. And that's, not really getting at the nuances and all of the diversity that we see in folks' sexual practices. And especially when we're thinking of who's eligible for PrEP, it's really important to be more comprehensive and more inclusive than that. And so, when we're bringing this up, it's important to also contextualize why you are asking a patient about their sexual health or their sexual history, especially when working with transgender and non-binary patients. They may have had experiences with trauma in accessing healthcare, which can include doctors or other healthcare providers asking about their bodies or their genitals or their sex lives when it's not relevant. So, right, if someone is in the emergency department with a broken ankle, you probably don't need to ask. And folks maybe have had bad experiences with that, but sometimes, it is often relevant to folks' health. If someone is presenting for STI screening, that's a fairly, obvious situation where it would be relevant. But other times you should kind of signpost something like, sexual health is an important part of our overall health, and it's something I discuss with all my patients at their annual physicals. Is that okay if we talk about now? And then approaching this really in a way that normalizes it and then normalizes a wide variety of sexual practices, asking open-ended questions, and then avoiding some assumptions, either on, based on what your patient or client looks like or what practices you think they might be engaging in. So this is a great resource. The CDC has developed these 5 Ps, as they call it, for taking a sexual health history. And those are partners, practices, protection for STDs, past history of STDs, and prevention of pregnancy. And then the Fenway Institute out of Boston kind of adapted that and included 3 more Ps, which are preferences, pleasure, and partner violence. What do folks think is gained by adding those 3 additional topics of preference, pleasure, and partner violence? I think this came up a couple times in the questions that folks brought up in terms of asking about, asking about pleasure or partner violence. Yeah, so Ms. Jai had said that preference allows for bodily autonomy, allowing the patient to share how they feel about their body and to be respected in that language. I think that's great. So this is really about kind of helping make patients feel like they're invited and comfortable in the conversations that we're having. And then so people can kind of read through some of these questions here, but you can see it's really focusing on open-ended questions. How do your partners identify themselves? What types of sex are you having? What are other ways you protect yourself from STIs or from HIV or from pregnancy, if that's relevant? Yeah, Ty bringing up that including pleasure helps us understand what pleasure means, because that can be different for different folks. And then here's the last, the kind of continuation of that table with the pregnancy, pleasure, and partner abuse. So certainly don't need to ask every single one of the questions in this table with every single patient, but these are just some ideas to kind of start brainstorming and thinking about how you can bring that up in your own time when you're discussing with patients or clients or whoever. And now kind of moving towards talking about PrEP, why do people think this is important to talk about these topics with patients when we're discussing PrEP? So what does the sexual health history have to do with discussing PrEP? Risk behaviors, exactly. Yeah. So when we're talking about PrEP, we're talking about preventing transmission of HIV, and that really does come down to risk behaviors. Right. So identifying if people have multiple partners, it allows you to have conversations about how PrEP might protect against HIV, but it obviously does not protect against other infections or against pregnancy, and helps inform as the Denver Health Clinic who would benefit from PrEP. So these questions kind of acknowledge the variety of ways that patients might experience and engage in relationships and sex, and is more inclusive of gender diverse identities for our patients and their partners. And because eligibility for PrEP, and specifically for the different types of PrEP, does depend on folks' sexual practices and their risk for HIV, obtaining this history is really important to determine kind of who is eligible for PrEP, who to talk about with PrEP, and what specific form of PrEP folks would be eligible for. Okay, and we've gotten some of this coming up in the chat, but any other like open-ended questions or things that folks are important or think are important when conducting a sexual health history? I've looked at or looking through the chat. So yeah, so talking about what risk of activities people engage in. If folks have abusive partners, they might not be able to use condoms, so other ways that people can protect themselves. Yeah, just generally, are you happy with your sex life, right? Like I think we focus a lot on medicalizing or diseases and stuff related to sex, but like it's supposed to be fun, right? So like, are you happy with it? How can we add that element of pleasure and kind of bring that up? Okay, awesome. We'll keep all of this in mind as we go transition to more talking specifically about PrEP and how you can kind of engage folks in these conversations. So can someone please tell me, what is PrEP? What does it stand for? The daily pill that prevents. Whoever was just trying to talk, go for it. Yeah, pre-exposure prophylaxis, exactly. So that's what it stands for. And then I've seen a daily pill that prevents HIV, also now a monthly injection, exactly. So PrEP is the antiviral medication that when taken consistently is highly effective at preventing the transmission of HIV. As folks have commented, it can be a daily pill. That's kind of how it was initially FDA approved and released. It's now also an injection that you get every 2 months, or it can be the same daily pill, but instead of being taken daily, is just taken around the time of sex. PrEP reduces the risk of HIV from sex by up to 99%. And we're not going to focus too much on injection drug use today, but it's also important to note that it reduces the risk of HIV from that by at least 74%. We'll bring this up kind of when we go through the different indications for PrEP, but it's important to know that in terms of the data and who has been studied for this, there's really not much data for insertive anal or vaginal sex, so like topping, or for sex with, for folks who have had gender affirming bottom surgeries. So that's sex with a neophallus, which is like the surgically constructed penis that transmasculine folks might have, or for a neovagina, which is the surgically constructed vagina that transfeminine folks might have if they've had surgery. All right, so here's our first poll. Sorry, Misty, I did not give you a lot of warning there. So you should see a poll popping up. So for which of the following patient populations do you routinely author or speak to about PrEP? And there's a lot of options here. These options do not encapsulate every human in the world. But we'll give you guys a little bit of time for that. And you can, this is a select all that apply if you missed that part.
All right, Riley, I am going to end the poll and share the results now.
Okay, awesome. All right, so we see a lot of folks talking about this with cisgender men who have sex with men, with trans men who have sex with men, well, cis women who have sex with men. Okay, so good variety. So lots of people are talking about this with lots of their patients. I see the gender health clinic, so they talk about PrEP with everyone. That's great. And we'll get into why that is important. And there's one more poll now. How comfortable are you counseling transgender and non-binary patients about PrEP, or if you are a provider, prescribing PrEP to transgender and non-binary patients? Do like 10 more seconds. Oh.
All right, Riley, I'm going to end the poll and share the results.
Okay. So great, it looks like a lot of folks are very comfortable, or at least somewhat comfortable. If you're neutral, or if you didn't respond to the poll and are not as comfortable, that's okay too. Our hope with this presentation is that we can bring more folks up on the comfortability scale here. All right. So what specific things for folks who are really comfortable working with trans and non-binary patients in terms of prescribing PrEP, are there specific things that make you more comfortable with that? Or for folks who were more, who responded that they were more neutral on this, is there anything that makes you less comfortable or uncertain, or you know, where you feel like there's a gap there when working with trans and non-binary patients and prescribing PrEP? I see Matea, being part of the population, that is something that I'm assuming you meant increased comfort with this. Great, so it sounds like a lot of folks having experience, you know, personal experience with this helps promote comfort. Talking equally about sex with everybody helps promote comfort. Yeah, so here's Stuart bringing in, you know, if you're effectively inquiring about sexual behaviors, right? So that importance of taking a comprehensive sexual history, then you can discuss PrEP as appropriate. Is there, Machai, did you have your hand raised?
Yeah, I was a medical case manager, and so I would do the intake, and it was standardization of the questions, so it was easier to talk about PrEP with folks, but also the oftentimes folks would be more comfortable talking about like sexual behaviors with me, or like the ways that they were engaging with me, versus when they were in front of the provider, they'd kind of like freeze up or expect the provider to start the conversation. And the provider didn't always start it. So I think that that helped as well, that I was seen as like a different part of the clinic.
Wonderful, thank you for sharing that. Yeah, the importance of making patients feel like they have a safe space to share their experiences and their, you know, their behaviors and talk openly about it is really critical here. Great, and you know, thank you everyone for all your sharing in the chat. One of the purposes of this COP is to increase folks' comfort in this area, and so if that's something that you think you would like more support on, you can request CDA assistance for that. All right, so getting into who is eligible for PrEP. This is, I think I pulled this from the CDC. Who do we see depicted in this brochure for PrEP?
I see folks who I perceive to be cisgendered men.
Yeah, so I see a lot of masculine presenting looks, it seems. And it seems like, yeah, agreeing, you know, someone thinking these are probably gay men, gay cis men is generally the vibe we're all getting from these brochures. And that's, you know, in the United States, the main discussion around PrEP has generally been in regard to, you know, presumably cisgender men who have sex with presumably other cisgender men, right? So gay cisgender men. There has absolutely been increased discussion about transgender women, specifically trans women who have sex with cis men. I think there's a new, like a Discovery ad on TV, if you, whatever, you maybe have seen that has, I forget, woman whose name I'm blanking on, but someone who's imposed, who's a transgender woman. But generally, this is still, you know, a somewhat specific demographic that's being talked about. But we know those are not, you know, the only demographics at risk for HIV, or the only people who are eligible or who should be included in discussions around PrEP. So thinking back to session 1 that Nevaeh facilitated last month about who in the US is at risk for HIV, and it seems like folks have kind of mentioned some of this over before, but who should we be talking about PrEP with? Awesome, yes, everyone, great job. Because we know everyone, again, it depends mostly on sexual behaviors, but really everyone could potentially be at risk for HIV. So this is data from the CDC tracking HIV diagnoses, and they do that along 6 transmission categories. So they track male to male sexual contact, heterosexual contact, injection drug use, both of those things. And then other and perinatal are not on this, but the most recent data we have from 2019 shows that the highest rates of transmission were amongst male to male sexual contact. However, when these are the only 6 categories that you're measuring, that doesn't really tell us much about, transgender women or transgender men or non-binary folks or, that whole other variety of sexual practices that exist out there. So those trans people specifically are really poorly represented in these data. And when we look at the intersections of race and gender and sexual orientation, we know that Black and Latino or Latinx MSM have higher rates of new infections than white MSM. We still don't have a lot of great data on HIV amongst transgender people, although there are newer studies coming out. One more recent one of transgender women found that amongst the women who were studied, 62% of the Black transgender women in that group had HIV compared to 35% of Latinx and 17% of white transgender women. So we see, again, the intersections there of race and gender. And unfortunately, data on transgender men and non-binary people is even more sparse. There was one study fairly recently that found that based on behavior and sexual health practices, 24% of transgender men in that study were eligible for PrEP based on their sexual activity, but only a third of those patients had actually been counseled on PrEP, and only about 10% had actually received PrEP. We see a huge difference in folks who could potentially be on PrEP and those who are actually getting the counseling and getting on the medication. So when we look at the CDC recommendations for PrEP eligibility, they're actually fairly broad. So they recommend that all adults and adolescents be informed about PrEP, and then PrEP be specifically offered to persons without HIV. Again, that's the key part, but it's only for folks who do not currently have HIV, and who have had anal or vaginal sex within the last 6 months with either a partner who's living with HIV who has an unknown or a detectable viral load, partners with unknown HIV status and who have inconsistent condom use, or any patient who's had a bacterial STI like gonorrhea or chlamydia within the last 6 months. Separately, again, any folks who use injection drugs within the last 6 months and who share injection equipment. So at least the counseling part and the first point about all adults and adolescents being informed about PrEP, I think is really important because that, again, invites that conversation about behaviors and risk factors, and that will enable patients to, respond openly to a risk assessment question, to discuss PrEP with their social networks and their peers and other folks who might benefit from its use, and just kind of get more knowledge about PrEP out there in the community. Patients might request PrEP because of concern about acquiring HIV, but they might not feel comfortable reporting sexual or injection drug use behaviors because they might anticipate a stigmatized response. So for this reason, after attempting to assess patients' sexual injection behaviors, people who request PrEP should be offered it, even if they might not specifically fit into one of these risk factors or behaviors. A side note here, I have had folks ask about the risk of HIV transmission when sharing injection equipment used for hormone therapy or for like silicone injections. HIV absolutely can be transmitted through intramuscular or subcutaneous injections, such as those used for hormone therapy. And so if a patient is consistently sharing injection equipment, like to do their hormones, particularly if they're sharing with unknown partners or with a partner who has HIV, I would recommend PrEP education alongside talking about safe injecting practices. Again, we don't have a lot of data in this field, but we know that HIV can be transmitted through things like a needle stick injury, which is kind of like a subcutaneous injection. And so I think these folks would still fall within that category of eligibility. And we have a great point here in the chat about adults across the lifespan. So folks of any age, including elder patients, folks who are on Medicare, should be having these conversations about PrEP and screening for eligibility. All right, so going into one more poll. So this first question is going to ask specifically about Truvada. Who is eligible to use that? And again, signposting here that these lists of people do not encompass every person in the world or every sexual practice or identity in the world. I was just trying to capture a reasonable number of them.
I will give it about 10 more seconds, Riley.
Great.
All right, I'm going to end the poll and post the results.
All right. So looking through, and we'll cover this on the next slide. But good, we have a lot of variety there. And then our next poll is going to ask the same question, but for Descovy, which is the other oral pill that's approved for daily oral PrEP. So same question, but for Descovy.
All right, 20 more seconds and I will end the poll for you. Perfect, sharing the results now.
Awesome. So we'll let people scroll through this a little bit. Got cisgender men who have sex with women and who have sex with men, and then kind of a varied response to the rest of them. So let's look through together at what are the actual, FDA approved populations for the various types of PrEP. So for Truvada, which its fancy name is emtricitabine tenofovir disoproxil fumarate, or F/TDS. For many reasons, I'm going to continue to call it Truvada. But for Truvada, anyone in the world, anyone who is at risk through sex or injection drug use is FDA approved for that. For emtricitabine tenofovir alafalumide, or FTAF, or Descovy, which I will continue to call it Descovy, is persons at risk through sex, but it specifically excludes people at risk through receptive vaginal sex. And we'll get into why that is. And then for the new injectable cabotegravir or Apretude, it's again anyone at risk through sexual exposure. So as you can see, the FDA approved indications are fairly broad. These approvals come from the clinical trials that were used to study the medication. So Truvada was initially studied in 3 studies globally. One included HIV negative men or transgender women who were having sex with men and who had high risk behavior for HIV. It's also been studied in HIV serodiscordant heterosexual couples. So that's a heterosexual couple where one partner is HIV positive and one is HIV negative. And it's been studied in adolescent MSM. That study didn't, I presume that was cisgender men, although the study doesn't really, doesn't specify that. And so that's where these approvals come from. Interestingly, you will note, well, actually, we'll get into this of who is not included in that category. For Descovy, those studies only included cisgender men who have sex with men and transgender women who have sex with men. And that's why it's only approved in those populations and not for people at risk through receptive vaginal sex, because it was not, that population was not included. I see the question in the chat about Descovy excluding people with neovaginas or people transgender women who have had like gender affirming surgeries. I do not believe that they were included in the trial, or at least not like explicitly included, but it can be hard to parse that out when we're reviewing all the trial data, because a lot of times they just don't even comment on it. Okay, so who fits into those categories and who does not fit into those indications, or which populations have not been studied? So we've already talked about, folks who have had gender affirming surgeries have not at least been systematically included in studies in a way that makes it so you can make sense of the data. Who else is not included? So we talked about cisgender men who have sex with men, transgender women who have sex with men, and heterosexual serodiscordant couples. Yeah, so teenage girls not included, transgender men have not been included in any of these studies, again, at least not explicitly so. Good. So we see, within that clinical trial data, transgender and non-binary patients, the only ones who have been systematically included specifically were trans women who have sex with men, which again, it's great that more trans people are started to be included in these trials. We still have a long way to go before the trial data actually matches the real life diversity of our patients in terms of their genders and sexual orientations and sexual practices. All right, so thinking about that, I'm gonna go through a patient case here and kind of apply what we've learned about PrEP eligibility and counseling around PrEP. So as we go through this, I want you to think about how you would counsel this patient about their risk for HIV, whether they're eligible for PrEP, and specifically which forms of PrEP they would be eligible for. So this is a real life patient who I saw, who's a healthy 30-year-old patient. They identify as non-binary and they were assigned female at birth, and they presented to my clinic for STI testing. So what questions do we want to ask this person when taking a sexual health history? Any questions? We just want to, okay, STD testing, here's your panel, right? What are your partners? What parts go where? I love that. Who are the partners? So again, this is all of using, we should fall back here on all of our 8 Ps that we learned about previously to help guide our questioning. And so we go through that with our patients. And we learn that they identify as pansexual, and to them that means that they're sexually attracted to people regardless of sex or gender identity. They have a history of chlamydia that was treated 2 years ago. They are not interested in becoming pregnant, and they have a Nexplanon, which is the implanted device for contraception. They are satisfied with their sex life, they feel safe in their relationships, and they have never engaged in transactional sex. So in getting into they like asking about previous partners. So they report 3 current sexual partners. The person they identify as their primary partner is a transgender man who is living with HIV. This partner has had phalloplasty or like bottom surgery. They have condomless receptive anal sex with this partner, and the partner is on antiretroviral treatment and has an undetectable viral load. They have, oh, here we go. Sorry, they have another partner who's a non-binary assigned female at birth person who has had no previous surgeries, and they primarily have oral sex with that partner. And then they have a partner who's a cisgender man who identifies as gay. They have receptive vaginal sex with that partner and use a condom about 50% of the time. And that partner also has anal sex with other cisgender men. All right, is everyone keeping up? So the patient wants to know which partners are they at greatest risk for contracting infections and how to best prevent infections, including HIV. How would you approach counseling this patient? In what ways are they at risk for HIV? And you can get, be specific about which partners you would be most concerned about transmitting HIV, or, thinking from kind of a harm reduction standpoint, how could this patient protect themselves from HIV and from other infections.
Some things that come to mind for me are first acknowledging the things they're already doing well to reduce risk. So they're using condoms 50% of the time. What about those times changes the fact that they would use a condom versus when they decide not to use a condom? The fact that they are talking to their partner who's HIV positive about being on antiretrovirals, and acknowledging the things that they're doing well to protect their health, and then discuss PrEP as an additional protective measure that they have more control over compared to the measures that are under the control of their partners. And then talking about site-specific testing as well for STIs, that there can be STI risk with any of the sexual partners that they have, and just in the ways that they're engaging. And so have they considered site-specific testing in the throat or the rectum or front hole or vagina or whatever language they're using?
Awesome, thank you. And folks, please feel free to unmute and chime in here. I want this to be as much of a conversation as we can have. I see in the chat letting them know what behaviors are specifically are higher risk for HIV, specifically the cisgender partner, letting them know about PrEP, and then anything preventing them from using condoms the other half of the time. Someone else had commented focusing on the cisgender male partner that's what people are at least the most concerned about in terms of transmitting HIV and other infections. Anyone else? Anything people want to bring up with this patient?
I agree with what Ms. Jai and everyone has said so far. I know that typically I would approach it with asking them to tell me more about why they're where they think their risks are coming from and what maybe prompted it, just so that I had some additional information, what information they know, I could fill in gaps and also see if there's something else going on there, particularly around the 50% condom usage, wanting to make sure there's no potential DV or coercion happening there. So I would first approach it with this inquisitive of, oh, tell me more about why this is worry, other than just general health screening.
Perfect, thank you. And I see a couple of comments about the patient being a great candidate for Truvada. Can either Desiree or someone in the Denver Health Clinic share with me why they think that?
As far as the couple, correct? So the previous case study, I would say that they're a good fit for PrEP, primarily because one person is living with HIV and another one, and the cisgender gay male partner does report, engaging in being engaged in sexual activity, and he's also engaging in sex outside of the relationship. And there's also a 50% condom usage. So with that, I say that that's the best bet. The way that I bring up PrEP, honestly, is by telling folks that it's just another tool to put in their toolbox. But I would highly recommend it as well, just for those reasons.
Awesome, thank you, Nevaeh. Yeah, and we have some folks in the chat saying also, again, focusing in on that with that partner, and then because in terms of Truvada versus Descovy, because our patient is having vaginal sex. And then someone bringing up the injectable PrEP, and yeah, that's also a great point. So yeah, having, this is a real patient of mine, having a informed discussion about their risk for HIV was somewhat challenging because this patient is not represented in any of the clinical trial data that we have, right? I'm a doctor, I like clinical trials and being able to say, I know this medicine works for you because it has been studied in 5,000 people who look like you and act like you, and that does not exist for this patient. Particularly when we start talking about trans patients who have had gender affirming surgeries, the huge variety of genders and orientations and body parts and things that people have or don't have or what they use for sex it's so diverse that they don't really fit in those convenient boxes like MSM that are what's studied in our clinical trials. So for this patient, the first thing I said was, you know, I'm going to talk to you about PrEP and answer your questions and stuff, but this is all in the land of, you know, applying what I know about medicine and trials to you in a way that like it doesn't perfectly fit. None of this is backed by super hard evidence or randomized controlled trials, but I think it still, you know, applies and they're still eligible. So that said, I think the patient would be obviously a candidate for PrEP, like folks have mentioned, and specifically with Truvada. Likely not with Descovy, since it's not been studied in people having receptive vaginal sex. We talked about that the partner who, you know, I think a few years ago or in certain circles, people might have focused more in on the partner who is living with HIV as like a person that they would be more concerned about transmitting HIV. But, you know, I told my patient, as long as you know that your partner is undetectable and you trust that and that they're taking their medications and stuff, then that's actually probably fairly low risk, because we know like if someone is truly undetectable, they're essentially not able to transmit HIV. Also because that partner had had bottom surgery, so they have a neophallus, which this is again kind of just applying what we know about these surgeries, but for folks who don't know, that type of bottom surgery, it actually uses a skin graft, like typically from someone's arm. And so the actual skin cells on the penis that they're using when they're, you know, engaging in sex with the patient, with my patient in this scenario, is made of skin cells, not of a mucous membrane. So there's probably a lower risk of transmitting HIV. They also don't ejaculate, and so the exchanging of bodily fluids is not really there in the same way that it would be in the studies of like cisgender MSM. And so I think probably the risk of transmitting HIV is fairly low in that partnership or in that dynamic there. Partner B, who was the non-binary assigned female at birth person, also pretty low risk since they're primarily having oral sex. So partner C, who is the cisgender man who's also having sex with other men, is probably the highest risk. And since they have vaginal sex, I thought that Truvada would probably be a better option. After December 2021, when this was approved, this patient would also be eligible for the injectable PrEP. Okay, that was a lot of information. Before we move on to the specifics of actually prescribing PrEP, what questions do folks have? Anything else that people want to chime in about the case discussion or, you know, similar cases that they've had? Please feel free to unmute yourself or use the chat.
I just wanted to add in terms of like candidacy for PrEP. One of the challenges we saw was either insurance not covering it before it had the USTPS designation, and also like the same concern around cabotegravir or like insurance not covering an injectable PrEP option. And so it might be a good opportunity to connect someone to someone who does like insurance navigation or something of that nature, just so they can get more information around how this could potentially impact other aspects of their life, like finances.
Yes, very important point there. And just to expand on that a little bit, so that was it's really critical having the USPSTF grade A recommendation for PrEP is something that plus the Affordable Care Act makes so that all insurances like have to cover that as a general preventative healthcare. That does not mean that all insurance has to cover all types of PrEP. And so I think that's going to be a, you know, ongoing discussion, especially now with injectable PrEP. And we can talk about that more once we talk about the specific forms. Okay, so I'm going to go through now kind of the specific prescribing and monitoring. Again, please feel free to unmute or chime in with the chat if there's any questions that come up. So for daily oral PrEP, this is like with Truvada or Descovy, a pill that you take every single day, what was initially FDA approved. There's some initial labs that you need to get for those patients that I'll list out here. So they have to have an HIV test because that needs to be negative, hepatitis B testing and hep C testing, getting a creatinine or a basic metabolic panel because there are certain contraindications based on people's kidney function. Getting a lipid panel because Descovy can impact folks' cholesterol levels, so it's good to have a baseline there. And then doing STI screening. Again, I think someone has put in this. I'm like, what parts are you using? What should we screen? here's all the options and let patients choose whatever's relevant to whatever they've been up to. So that's universal screening and recommended for everybody. And then a pregnancy test, if relevant. I usually kind of talk to my patients who are assigned female at birth. If they're ever having any kind of sex with someone's body that produces semen or sperm, you might be at risk of pregnancy. And we can talk about ways to prevent that if it's not something you desire at this time. I remind them that hormone therapy is not contraception, even if someone's not having a period, and then kind of invite that conversation based on, again, who they're having sex with and what they're interested in. And PrEP is safe to use during pregnancy and during breastfeeding. Once someone is actually on PrEP, we'll typically do, I should note that these protocols sometimes vary by clinic or by institution. At my institution, we do typically repeat a HIV test in 1 month, and that's just to detect anyone who had not yet seroconverted on their initial lab. So if you were exposed to HIV like the day before you got tested and started on PrEP, your labs would not reflect that yet. So you repeat the test in a month. And then every 3 months, we're doing an HIV test, either the antibody antigen or the RNA test. And that's because, PrEP is highly effective. It's super rare that someone would contract HIV while on it. But if they were to, Truvada or Descovy is only a partial treatment for HIV. So if they're still taking that medicine, that would potentially increase their risk for like resistant mutations for HIV. We check kidney function after 3 months and then annually, and then STI screening, again, kind of depending on practices and risk factors. And then every 6 months, checking on people's kidney function if they're older or if they had slightly reduced kidney function to start with. And at least every year checking on kidney function, checking lipids or cholesterol if they're on Descovy, and then checking for hepatitis C if there's any risk factors there. This is that same thing, just in a table format for the people who learn that way best. And this is all from the CDC like clinical practice guidelines, which is a great resource to have. And we can also send these slides out for folks. So counseling, most common side effects for Descovy and Truvada is just some upset stomach. Usually that gets better after about a month or so. There are some more severe but less common side effects for Truvada. We worry about that renal dysfunction and a decline in bone mineral density with very long-term use. And then for Descovy, we talked about the lipid or cholesterol changes and also associated with some weight gain. All right, someone had mentioned in the chat something about like on-demand or as needed non-daily use of PrEP. So I wanted to bring that up. This is something that has been studied, but is not FDA approved. So not approved in the US, it is used more regularly in Europe. Is that something that folks are prescribing? I'm just curious if anyone in the group here can share in the chat if that's something that they're counseling patients on or prescribing. No, okay, great. So the way it's done, yeah, it looks like Denver Health does. We've done some counseling. So I think it's something that's worth talking about with patients. The way you do it is take 2 pills between 2 and 24 hours before sex, 1 pill 24 hours after that, and then another one 24 hours after that. It's been studied mostly among gay and bisexual men who have anal sex without a condom. It's not really been studied in heterosexual men, women, or in transgender people. Interestingly, while it's thought to be ideally for folks who are just not having sex that often, so don't want to take a pill every day, when you look at the clinical trials that studied this 2-1-1 usage, a lot of people were on average taking 3 to 4 doses of this per week. And so when you kind of count up all these pills, they were actually taking it pretty frequently, like not exactly daily, but I think that's important to bring up that the data on truly doing the 2-1-1 like once a month or something is not quite as robust as what it's approved in Europe for. That said, the kind of as needed use can be helpful for folks who don't want to take a pill every day or who are not having sex that often, but when they do want to have a way to prevent HIV. it's important to talk to folks about their sexual behaviors to kind of empower them to make those informed decisions about when to take as needed PrEP. And then if they're using it more than once a week or so, it probably makes sense for them to just do it daily. Someone brought up, yeah, concerns about like how it's used in people with vaginas, because like the way that the medication actually accumulates in tissue and it's correct, it's not been studied nearly as much in those populations for us to know for sure how effective it would be. So yeah, pointing out that here, it's only been studied in MSM. So that's generally who I'll talk to about this. If other patients bring it up, I'll talk with them about it. I'll share what I know and kind of have an informed decision conversation around that. The injectable form. So this is the hot new thing. It's a shot that you get every 2 months. It was FDA approved in December for everybody at risk for HIV through sex. I just see the comment 211, I believe, was studied just with Truvada. So injectable PrEP, the main concern is this tail. So you get a shot, it's studied to last for 2 months and be effective, but it clearly stays in your system some beyond that. And so if you do acquire HIV during that tail, there is a slightly higher risk of drug resistance. So just something to talk about with folks. The injectable PrEP was only studied it was studied in like cisgender men and women and in transgender women, but it is approved for everyone, even though it was not studied in transgender men. And then this is my last point here. Sorry, I know we're getting close on time. So main kind of highlights to think about for trans and non-binary folks is PrEP is safe to use with any form of hormone therapy, assuming someone's kidney function is normal. Folks who have had post-operative, who've had like bottom surgery, things to think about is, I think theoretically there is probably a lower risk of contracting HIV just because of the skin grafts that are used. Same with we talked about like phalloplasty or like transmasculine bottom surgeries that use a skin graft typically from someone's arm or their leg. For neovagina or for trans feminine patients, that skin graft typically actually comes from the penis, but not using the glands. And so it's also like a skin, not a mucous membrane. But that is all completely theoretical and has not actually been studied. So these patients are still obviously eligible for PrEP and should be counseled on PrEP. Okay, I see there's one question. How many days after receiving the injection does it provide maximal protection? For the injection, I'm not super certain. I haven't prescribed. I think, yeah, someone else says we don't really know. It's been studied a couple different ways. One was if you take an oral pill for like a month or so before you get the shot, but that was more out of concern for a drug reaction, because it really sucks to find out you're allergic to a medicine after you got a shot of it that'll last in your body for 2 months. So I don't know if any of the thought there was that the daily pill would like build up a level in your system. But you can, in the US, they recommend doing it either way, that you can offer people the daily pill or just start with the shot. The 2-in-1, so the efficacy there is really hard to say. Out of the studies in Europe, it was like highly effective, I want to say around like 85%. But again, when you looked at how often those patients were actually taking it, they were taking it like 3 to 4 times a week. And in the daily PrEP studies, they count 5 times a week as like good enough to still keep those patients in the trials. And so it's really not as clear how much that those trial data apply to someone truly taking it like once in a blue moon.
Thank you so much, Riley, for sharing this information. Thank you for the great case example. Walking through that case example and having some discussion was profitable for all of us. So can we give Riley a round of applause, some thumbs up? Great job. Thank you, Nevaeh, for starting us off with session 1 a couple of weeks ago. So this concludes several different things. So 1, this was the end of our series on equitable representation in sexual health and HIV prevention services. 2, this serves as the May West Region Learning Convening. We are going to be sending an evaluation out to people. Please complete the evaluation. We need your feedback. We improve through feedback. Feedback is a gift, and it is a gift that we love. Secondly, for those of you who have attended our communities of practice for our transgender and non-binary program, our next event is going to be Wednesday, June 15th at 11 a.m. Mountain Time. And the title is What You Don't Know But Should, Celebrating Transgender and Non-Binary Stories. Please join us when Nevaeh Anderson and Callan Smith are going to tell us all the things that we didn't find out in history books. All right, have a great day, drink some water, and be safe. Love someone other than yourself today. Have a great one.